Maddie's here. Now you have quorum.
Oh, am I hearing I saved the day? Happy to
You
again.
there you are to
saved the
save the
day.
day.
Not the first time.
Mighty Maddie.
Okay. You can now begin your meeting.
Wonderful. Thank you. All right. Good morning, everyone, and welcome to the Joint Board of Health and Hospitals meeting for the St. Louis City Department of Public Health. Happy Thursday. And I'd like to start by calling the meeting to order. And I make a motion. I would like to approve the Zoom meeting minutes or the Zoom video from March 4th, 2021. May I have a motion, please, to approve the minutes?
So moved.
Second.
Thank you. The minutes are approved. So let's get going right into the agenda. And we will start with Dr. Eccles for our COVID-19 update.
Good morning, everyone. So what we're seeing in the city of St. Louis, we've essentially plateaued a little bit. And so similar to what we're seeing in St. Louis County and other parts of the region, the numbers have remained relatively stable. However, one good sign is that the average number of total hospitalizations related to COVID-19 continue to go down. However, while talking with the St. Louis Metropolitan Task Force hospitals, other conditions that require medical treatment and care are starting to pick up. And so hospitals are still busy during this time. Our focus continues to be at this time increasing the number of individuals who receive the COVID-19 vaccine. So we've had a total of 16 mass vaccinations in the city of St. Louis. And our total number of vaccinations administered is well over 15,000. But our efforts continue. There's still a lot of misinformation about the vaccine circulating in our community, particularly in communities of color. So we're being very intentional about engaging other organizations, community-based organizations who have relationships with those communities to get them to our events. For example, we're working with Casa de Salud and some of their partners to get the Hispanic and Latinx community to our event, as well as individuals from the Vietnamese community. And we continue to work with organizations such as the St. Louis Housing Authority to get those elderly individuals, particularly minorities who are need access to the vaccine. We're creating opportunities for them to be vaccinated as well. And so as we continue to work with those partners, our hope is that we will continue to dispel the myth that people of color do not want to receive the vaccine. When doing our first event in North City at the Omega Center, it was very clear that African Americans do want the vaccine, but we have to create opportunities for them. During that event, we served over 1,300 City of St. Louis residents, and over 90% of those individuals were African American. So there's a lot of interest in that community, but we have to do a better job of engaging them and creating opportunities and access points for them to receive the vaccine. And so our efforts there will definitely continue. But we'll also be looking at how we utilize the data related to COVID-19 to move forward as we adjust our COVID-19 related initiatives in the city of St. Louis Department of Health. We'll be using data to guide that process in our future decision making to make sure that we're meeting the needs of the community, but we're also doing so in an efficient and effective manner. We also continue to work with the Department of Human Services, Health and Senior Services, to get additional vaccines. So the allocation for the St. Louis metropolitan area has increased to 42%. With that comes almost a 100% increase in the number of vaccine that the city of St. Louis should be receiving weekly. And so that our allocation of Moderna vaccine will increase from 900 doses per week to 1,800 doses per week. And so we anticipate that starting next week. We held a meeting yesterday with the state and other representatives. And so we'll be also working with them for upcoming mass vaccination events, such as the mass vaccination event that'll be held in the city of St. Louis on the 25th and the 26th at the Forest Park Community College. The ultimate goal there is to vaccinate at least 2,500 to 3,000 individuals each day. So a total of up to 6,000 individuals will hopefully receive the Johnson & Johnson vaccine during those events. We're working to get the registration process up and running so people can actually register for those events. Based on the previous trends for the National Guard events, the registration capacity is typically tapped out within a few hours. And so we hope that'll be the same case for the city of St. Louis, because we really know that there's still a significant percentage, a proportion of individuals in our community that still need the vaccine. With that said, we also know that there's still a significant percentage of individuals in our community that remain susceptible to COVID-19. We were reporting a little over 20,000 confirmed COVID-19 cases. And with the population of 300,000, we know that there's still a lot of people who are susceptible to COVID-19 and potential severe complications. And so we continue to urge individuals in our community to implement those prevention measures, wearing a face covering, social distancing, et cetera, to further slow the spread of COVID-19. I'm still concerned, I think everyone in the region is concerned about the variants. So the UK variant has been detected in the St. Louis metropolitan area. And so we're really mindful of the impact that those variants can have on the health of our population. So one thing we don't want to happen is a repeat of the beginning of the pandemic, where we had our most vulnerable populations extremely impacted by COVID-19. And so we continue to educate our community but as more individuals become eligible to receive the COVID-19 vaccine, we hope that the uptake will also increase. But we also, as I mentioned before, need to make sure we're creating access points and opportunities for communities of color and other vulnerable populations to receive the vaccine, so there's proper coverage across the city, not just in certain pockets.
Thank you, Dr. Echols. Do we have any questions or comments about the current vaccine rollout or anything COVID related?
Dr. Mahdi has a question.
I just more have a comment. I had the distinct honor of being a vaccinator for one of the city's events. And it is just important for me as a matter of record to say how incredibly well run, how emotional of an experience it was as a woman of color, as a Black woman, let me be clear, who has seen the devastation and the statistics in our nation since the beginning of this pandemic, almost a year out. And to be in a city where we have a director of health who was true to his word following the data. You know, when I got there at 7:30 a.m., there were lines for blocks already of people lining up. Early in the morning, it gave me chills. And when I walked into the center, there was organization, there was planning, there was intentionality, and our leaders were there. But most importantly, there was in the room a joyful and hopeful atmosphere. I want to commend and thank Dr. Echols and your entire team for what you have been doing week in and week out. They don't have weekends off. You know, he is there bright and early with the rest of us. The rest of us volunteers get to pick and choose and plan babysitters, but they are there doing this work every single week. And there's a lot of debate within the public about how this has been done. And I just think I want to really be intentional about also elevating the work that Harold and Kimberly and the communications team has done. They have listened to the call of folks like Dr. Ross and myself on this platform, the messaging and the social media platforms. I mean, I was like, this is incredible. And, the only thing I would say is, as someone who has to, by some of the medical contributor work I do, what we're doing here is quite unique. So I just want to really thank people to continue to say, yes, there's people in the public who are like, why not me? And this invitation makes them wary. And I really commend the communications team. Have been doing a great job of answering some of the questions. I've been even answering some of the questions, but it has been phenomenal. So I just wanted to say thank you for what you have done. Kudos. We're just looking forward to even more. I also wanted to offer by way of data that, I wanted to thank Dr. Echols for centering in on the fact that it is clear that communities of color want these vaccines. The most recent data and national polling data has shown that African Americans who said they would not take the vaccine are 25%, whereas 39% and 40% were from Republican men, white non-educated men, and more rural populations. This is not to politicize an issue, but to really address the issue of within Black and Brown communities, this is all about vaccine hesitancy, which it is not. there's clearly an access issue. And so what we are doing is addressing that. And I believe we still need to do culturally sensitive, language specific education, but it's important to know that that data has shifted. I also wanted to bring to your attention that states like Montana and Utah have actually, as part of their first wave of vaccines out, said that they will prioritize communities of color. I know this can be a little bit of a contentious issue. People are, find it difficult to put race without an age restriction. But I think it's something that we must consider because the data has been very consistent about the disproportionate impact in both severe illness and death in Black and Brown communities.
Maddie, that was beautifully stated and on point, absolutely. I have a concern, and I think that as epidemiologists, as public health experts, we should call out the good, but be ahead of the curve when it comes to concerns. And my concern is the presence of the UK variant here at St. Louis, which Dr. Eccles mentioned. And the difficulty tracking this and other variants that may arise in St. Louis, in the Brazilian variant particularly, as well as the South African variant. And the fact that Dr. Eccles gave obviously the appropriate notation about the stabilization of the hospitalizations, not the precipitous decline that we would want, and we just don't know if we're seeing a plateau because there are more variants, because we don't have the appropriate testing, genetic testing, sequence data on all these cases. That's just a technology that hasn't quite gotten there yet. And so I just want to just state on the record that we don't know how prevalent this UK variant is, or rather, I should say, I don't know based on what I've seen. So, Dr. Eccles, what are your thoughts about that?
I'd agree. We don't know the prevalence. We don't know how far it has spread within our communities because of the lack of our ability to actually test more and more of those specimens for the different mutations. And so that's something that is typically led by the state and the CDC to increase that capacity, but it's also incumbent upon the private laboratories to adopt the protocols and equipment needed to detect those variants as well. And so at this point, we haven't received a lot of information from the private laboratories. We continue to have the dialogue with the state, but the state at this point is still dependent heavily on the resources that are provided by the CDC. But that's very limited as well because every state is relying on resources that are available by the CDC. And so we have to be, again, intentional about how we utilize funding that's going to be coming in from the American Rescue Plan Act to increase our capacity locally to detect, to provide a more efficient public health response and conduct more efficient surveillance activities.
Thank you.
Just want to say from what Dr. Ross said, I cannot agree more about the need for that. I would say that, again, it's important to be aware that that is an area of concern for the general public. The CDC, and I'm happy to send the specific website, has a particular page where they have information explaining each variant and then updating people on what the variants of concern are. I think what's important for us to highlight is not only that information maybe on our website and as a matter of communication as well, but also the up-to-date data about the fact that most vaccines are actually good against most of the variants, especially the ones that are circulating within the US, so that there isn't sort of this mass panic. I think it's important to understand that what Dr. Ross is saying is extremely important. We need data. Data is power. Data informs policy and allows us to protect our communities, but to also make sure that people do not believe that there is that what we have for them, what we have available by way of vaccines is not effective. And so I think that could be something we could focus on very briefly, even by way of educating our population.
Dr. McBride?
Yeah, real quick, and thank you for the powerful statements by Dr. Maddie and Dr. Ross, and I just want to agree with them 100% and thank all the hard work by the Board of Health, and just sort of follow up on that, and because I've been very critical of the vaccine supply rollout, and I'm glad to see that we're somewhat sort of turning the corner on that a bit, I hope. And I was looking at the state's website right now, and we're still behind the rest of the state in terms of percentage of the so we have 13% of the county of the city that's had percent initiating the vaccine, and the state is 20%. So so that does suggest that we are despite the hard work that we heard about from the mass vaccine event last week, and all the other hard work that's been done, we're still behind. And I'm glad to hear that the supply will increase, but it's going to take a few more weeks or more to sort of turn that corner, I think. So it's not time to put the foot on the accelerator or take the foot off the brake, or whatever the right metaphor is, because of the UK variant, because we need to keep putting shots in arms. As Dr. Manny pointed out, I have the same reading of the data as she does. If it's not really necessarily hesitancy that's causing the difference between African Americans and whites, we know that African Americans have half the vaccination rates of whites. I'm pretty convinced now that it's supply and access. So that's what we need to be doing. So it's supply, it's access, it's messaging, although I think our compatriots here are doing what they need to do. So what we can do is help with that messaging. And so anyways, let's just not take our foot off the accelerator in terms of the vaccine.
I think the governor also recognized that as well after they visited the area and actually looked at the data. So that's why the Missouri National Guard events, there'll be more Missouri National Guard events in the St. Louis metropolitan area. So we'll have 2 in the city of St. Louis next week. There'll also be events in, I believe, St. Charles County and St. Louis County. So they are starting to ramp up the resources that they're making available to the St. Louis metropolitan area.
Good.
Any more comments or questions? Thank you for the conversation about vaccine and vaccine uptake. And yes, I 100% agree it is an access issue. And given that we have a circulating variant in the St. Louis area, vaccinating efficiently and vaccinating more people is going to be protection against those variants. And some Moderna and the Pfizer do protect against the majority of the variants. So that makes it, putting the foot on the, I'm trying to get the right metaphor, Tim. You got all these metaphors in my head. Putting your foot on the gas is even more important now, even to protect against the variants. And I would like to echo the sentiment of the job the health department is doing to get vaccines distributed to the community. As I've visited several of the events, it's everyone from Dr. Eccles to Harold, Kimberly, the communications team, volunteers from the community, multiple people from the health department are pulling 12-hour days on weekends and to put together a very efficient vaccine event for the community. And it is really a phenomenal community service during a time of turmoil and around the globe, but in our region. So I just wanted to echo the thank you and a job well done, but we do still need to put pressure on those that are distributing the vaccine or that are supplying the vaccine to get ahead of the variants. I mean, at this point, we can't control the variants. I mean, we can still encourage COVID precautions, because we also we want to make sure that we're not, that the influx of vaccine or the increasing availability of vaccine doesn't mean that the community should become lax in COVID prevention measures as well. So I think we need to make sure that we keep that messaging for COVID prevention going until we do reach some level of herd immunity. so that the variants don't take hold. So hopefully, we can still, I think everybody's focused on getting the vaccine, which is appropriate, but until we're able to vaccinate enough folks, that we need to make sure that those prevention measures and mask wearing and still staying at home when possible are still out there, and then that messaging doesn't get lost, because it's still critical, so that we don't remain in a plateau, that the numbers continue to go down. Do we have any other comments or questions about vaccine distribution and rollout? All right, thank you. And well, we actually do get a little bit more information about COVID-19 and what's happened in the St. Louis city and surrounding area. So we have a 12-month COVID-19 report by Dr. Dominic Moshe and Neha Sastry. And please, I hope that I've pronounced your names correctly. Correct me if I have not done so.
Before they get started, so most of you, I don't think, are familiar with Dr. Dominic Moshe. So one of the priorities that was established upon the start of my tenure was the need for proper epidemiology oversight. And so we created a new position in the health department, which is the epidemiology bureau manager. And so Dr. Dominic Moshe comes with a wealth of experience, and I'll give him a short period to introduce himself to the City of St. Louis Department of Health, Board of Health and Hospitals. Dr. Moshe, you're on mute.
Sorry. Thank you, Dr. Eko. Yeah, good morning to all. I'm Dominic Moshe, epidemiologist with medical background. I've more than 10 years experience working as a clinician, research scientist, academician, as well as a project leader in different institutions in Africa, in Switzerland, and Boston. And now I'm here in St. Louis. I'm happy to join the department. Thank you.
Thank you. He's hit the ground running, so we're happy to have him on board. And before Neha gets started, so one of the things that we wanted to do is continue our efforts to be transparent with the data. And so we wanted the first case in the city of St. Louis was detected, reported back in March 16th of 2020. The specimen collection date was actually March 1st of 2020. And so we wanted to give the health department's Board of Health an overview of the data that's been collected over the past 12 months. There's actually an official report that will be published today, so be on the lookout. But right now, Neha Sastry and the team will provide a brief presentation on this data.
All right, good morning. As some of you might remember me, my name is Neha Sastry. I'm one of the epidemiologists with the City of St. Louis Department of Health. Trying to share my screen, I'm sorry. Okay, so I'm going to be going into a little detail about the one-year report in terms of the data that we've seen so far, the case counts, and where we've been, the vulnerable communities, as well as the specific regions that have been at risk. And I'm going to be also talking about vaccination data, which has been previously discussed. Some of the trends that were mentioned are very much seen in the City of St. Louis data. So if you have any questions, feel free to flag me down. I'm just going to pull up my notes. Give me one moment, please. Okay, we can proceed. So in the City of St. Louis, much of the trends that we've seen in overall case counts have been very consistent with what we've seen in the country as a whole. So there have been 3 waves with growing intensity each time. And the case counts gradually increased in the first 3 months, followed by a decline throughout the following months. However, towards the end of June, case counts began increasing again, reaching its second peak towards the end of July. And the third and largest peak of the pandemic here in the city thus far occurred during November and continued throughout the holiday season. And I'm going to talk a little bit more about the specific measures that were taken and where they placed in terms of the overall calendar of the pandemic. In the figure to your left, you will see that this is a representation of the 7-day average of new cases. So what this figure is specifically looking at is the average number of daily cases per week, with specific landmarks highlighting when the stay-at-home order was placed, when it was lifted, and when the third wave began, just because these are some of the key highlights. So in March 23rd, the stay-at-home order was put into place. The average number of cases per day would increase to 38 cases per day. That was the highest that it was since the beginning of the pandemic, and then it would decline to 17 cases. And it would stay relatively low until June 16th, when the stay-at-home order was officially lifted, and the second wave would begin. That following week, increasing from 17 to a peak of 89 cases, as visualized right here. You can see there was a dramatic uptick quite rapidly. As the summer progressed, case counts began to decrease, but then when the schools began reopening, there was the beginning of the third wave. So by November 29th, weekly average cases would be consistently above 100, reaching a peak of 160, and then would slowly decline. Right now, we have been, as Dr. Eccles mentioned, at a consistent count, but the third wave is certainly much higher than all the other times that we've seen a peak in cases. And the following will be looking at not only case counts by demographic information, but also by region and testing, as testing is very indicative of telling us the direction of case counts as well. If you have, as I mentioned previously, this is a preview of the report. There is more information in the specific report in terms of hospitalization data. So if you have any questions regarding that, please feel free to reach out or view the report upon its release. Testing, as I said, testing and percent positivity is very important in terms of us understanding the overall case counts and where cases, the direction of cases. The figure to your left looks at the 1-week average of percent positivity. And as you can tell, there was a dramatic uptick in percent positivity upon the initial beginning of the pandemic that kind of dropped and then has fluctuated since then, similar to the second and third wave of the pandemic as a whole. Since the week of January 2nd, percent positivity has decreased from a weekly average of 13.2 to 4.8, around 5%, the week of February 20th. Of 2021. The last time percent positivity was this low was in the beginning of September, as visualized, towards the end of September, the week of September 29th, when percent positivity reached its lowest at 4.4. That's the lowest it had been throughout the course of the pandemic. Historically, the WHO has recommended that cities stay below 5% positivity for at least 2 weeks before reopening. Obviously, the city has reopened since then, and while we continue to monitor percent positivity, staying below 5% is a great sign. So hopefully that continues moving forward. So looking at testing as a whole, while case counts have fluctuated, testing counts have increased since the beginning of the pandemic. The peak of testing was the week of November 14th. At an average of 1,485 tests per day. It does not correlate with, so there are a couple of reasons why this could be the case. A lot of people went out for Halloween, and that could explain why 2 weeks following Halloween, there was a great amount of testing. But also, I think that there was an increase in testing leading up to the Thanksgiving holidays. And that also could have been driving the increase in percent positivity that we noted here during that same time period. So since that peak, the week of November 14th, testing has decreased, but not by, and has decreased by a significant amount given the peak that was there, but testing has decreased to 786 tests per day during the last week of February, but that it's still relatively high and has stabilized at an average of, I want to say, 800 to 850 tests per day. So despite the decrease in testing, percent positivity is also low, and this implies decreased disease transmission. If we were noticing an increase in percent positivity, but case counts were testing was remaining at a consistent average, we would recommend that there would be an increase in testing to ensure that the increase in percent positivity is not due to is not driven by an increase in case counts. Yeah. Okay. Move forward. So as we are viewing cases, it's important to also view it by demographic distribution. As we've discussed, African American communities and other communities of color have been sorely hit by the pandemic. So we're going to start looking at it by sex, and I wanted to compare the case counts versus the case rates. While females have a larger population here in the city, if you look to your left, the case rate by men and women has been fairly consistent with this small increase in case rate among men during the week of November 3rd to November 10th. Sorry. Case rate, despite cases being higher case rates have been higher among females as opposed to males, and that's driven mostly by a larger case count among women. So even when you control for population, the case rate is still larger among women. And this could be due to a variety of factors. I think we have data that examines women working in fields of service more often than men, therefore increasing the risk of exposure. When we look at the demographic distribution of case by race, in the previous 6-month report, we talked about how the 3 waves that were noted previously were driven by different races every time. Since then, we have updated that race demographic data in our own positive case counts. So that has changed slightly, but still indicates that specific races were driving the 3 waves that were noted. Case counts and case rates remain highest among African Americans, followed by Caucasians, and then Asian/Native Hawaiian and other Pacific Islander. The figure to your right examines weekly case averages by rate and also looks at it over time. If you look at the first wave, you'll notice, as I've previously talked about, that case rates rose predominantly among African Americans. And during the second wave, Asians and African Americans primarily drove the increase in cases. During the third wave, as I previously spoke about, during the 6-month report, it was Caucasians that drove the case rates. Sorry, excuse me. When we look at demographic distribution of race by sex, things change a little, as you can see in front of you. The figure to your right looks at case rate by race among men, and as you can see, African American rates are still higher compared to all other races, but overall are quite similar to each other. As I mentioned, during the third wave, it was Caucasians that were driving the increase in case counts, and this is visualized by men when you view the increase specifically among Caucasian men. But when we look at the data by female, we see that while African American women had the largest increase in case counts and consistently remained higher during the majority of the pandemic, with the exception of the third wave, where you can see that Caucasian women and African American women had similar case rates. Case rates among Asian women have remained relatively low. Now, there are specific peaks that are consistent with the case rates that are consistent with the waves of the pandemic. So around the same time that African American women and African and Caucasian women had case rate peaks, so were Asian women. But overall, the rates are much lower compared to other races, specifically among women. Now, this could be due to a variety of reasons. By looking at case rate, we are controlling for population count. So even with controlling for population count, the case rates are still low. It could also be due to greater adherence to COVID-19 guidelines, or it could be due to a variety of reasons. I think that would require greater examination in terms of health behaviors. So I'm reluctant to make any very specific conclusions as to why case rates among Asian women are so low. It could also be due to data portion on our end, not having enough specific data among Asian women. So moving forward, I think it would be something to really examine. When we look at case rates by ethnicity, and I've shown these figures below before, they are quite similar to they're the same to what was demonstrated in the 6-month report. But you'll notice that there are very dramatic increases among Hispanic, specifically Hispanic individuals. This could be due to high cases in proportion to the overall population. And again, is echoed in the figures to your right, where the case rates among Hispanic individuals, men and women, is much higher than those among those who are non-Hispanic. But there's a little more similarity when you look at Hispanic women. Non-Hispanic men and women, the case rates are pretty similar to each other. But when you look at this case rate by Hispanic women and men, you'll notice that case rates are a little higher among Hispanic women than compared to Hispanic men. So the following figure looks at confirmed cases. This is specific to PCR tests. As you know, there are a few others, and there is a little variance in positive testing, percent positivity and testing case counts when it comes to the specific differences in tests. But that is also included in the report. As you can see in this figure in front of you, however, when we're looking at confirmed cases by PCR, you'll notice that the majority of our cases are located specifically in zip code 63116. This is consistent with the data that I'll talk about a little later, where case counts are higher in South City. Now, this is probably due to the early investment in education and testing to North City. But as you can see, while case counts are still high throughout the whole city, there is a overall concentration specifically in the South City. When we look at COVID-19 case density, you'll notice that there are a few hotspots, specifically in Central West End, downtown, and overall the majority of South City. Now, I know that South City has a larger population, so that could be why these hotspots are there. But with Central West End and downtown, we can't just say that it's all located in South City. There's obvious increases in Central West End and downtown, and also a hotspot in North City, as reflected by our hotspot analysis, which is visualized on your right-hand side, that mirrors those specific areas. And again, this data is shown by specimen date collection date, as Dr. Eccles has previously mentioned, so the day that the individuals were tested for COVID-19. So these specific significant areas, as you'll notice, are majority in the middle of the city and South City. As I talked about, there was a great deal of early investment to North City just to, and you can see that has helped in terms of lower case counts and fewer hotspots in North City as opposed to South City. So the following is looking at hospital data trends, and this is going to be looking at the weekly average positivity percent positivities from BJC and SSM. Now, this data is, again, specifically BJC and SSM. There's obviously some other hospitals that have not provided the same amount of data that they have. So I'm going to be talking a little about the testing that was available. As you can see, the testing has increased dramatically in the beginning of the pandemic, and then fluctuated similar to the other pandemic trends. And then if you look at the COVID-19 weekly average positive test and percent positivity, you'll see that the 1 week average of positive tests has been consistent with the overall pandemic trends, while the 1 week average of percent positivity increased and then has decreased over time. Now, this could be due to an increase in testing on the hospital's end, but again, further examination of that from the hospital perspective would be needed. As we've talked about previously, we also were looking at vaccine dissemination and the data that was made available during that time. So the figure to your left looks at the 1 week average of vaccine dose dissemination. And when you look at the beginning, if you look at the light blue line, you'll see that that's the vaccine dose 1 dissemination since it began. And it started at 186 vaccines the week of December 14th and picked up as vaccine dissemination did as well. And then 2 weeks later, vaccine dose dissemination also picked up and began increasing, consistent with what you would expect with dissemination. Vaccine 1 was given out at a specific count, and then there was a slow increase in vaccine dose 2 as it was disseminated per medical standards. The only point of concern that we've noted is during this area in the beginning of March, where there was an increase in vaccine dose 2 and a dip in the first vaccine dose disseminated. So that could be due to a decrease in vaccine 1 dissemination, and could probably and we'll likely need to examine this further to make sure that a dip like this doesn't happen and that they are parallel to each other, increasing, and both are increasing as time goes on. When we look at vaccine dose by type, we'll notice that Pfizer is overwhelmingly the vaccine that is being most used, whereas J&J is very minimal. As you can see, it looks like there's only 2 columns on each dose, but it is there, and Moderna is the second most common vaccine, and Pfizer is the first. When we look at vaccine dissemination by geographic distribution, you'll notice that when we adjust for age, that both those receiving 1 dose and those who are fully vaccinated is largely located in the Central West End region, specifically these 2 zip codes, 63108 and 63110. As was mentioned earlier by Dr. Ross and Dr. Mahdi, the counts have been highest among Caucasians, and it's followed by African Americans. So as was previously talked about, it might not be just about hesitancy, it might also be due to lack of access. So as we move forward, it's obviously mindful to keep these in the forefront of our minds, as it very clearly is, because it was previously talked about.
Neha, can I interrupt briefly? Can you go back to that last slide?
Absolutely.
So one comment is the fact that a number of vaccinations were delivered to healthcare workers, which are concentrated in the Barnes-Jewish Hospital and SSM, rather St. Louis University. And so that could contribute to that density of dissemination in the 63108 zip code.
Absolutely, absolutely. Okay, so this slide looks at vaccination dissemination by race. As I previously talked about, vaccinations are highest among Caucasians. 46% of our vaccinations are occurring among Caucasians, and that translates for both dose 1 and dose 2. So Caucasians make up almost 50% of the vaccines that are being given overall, and then by dosage. But only 20% of the vaccines are among Black or African Americans. And given that we've talked about how high the case counts are among African Americans, and as I will talk about later, the fatality risk is also higher among African Americans compared to Caucasians and all other races, I think it's really important that we address the lower counts of vaccination dissemination, specifically among African American communities. When we look at vaccination dissemination by age group, we want to be seeing that in the figure to your left, that there's an increase in vaccination dissemination by age group, as opposed to the figure that we see. If you'll notice, those ages 60 to 69 have the highest vaccination counts, which is good to see, but that's followed by those ages 30 to 39. Now, as Dr. Ross mentioned, that could be because we're disseminating mostly to medical staff, and that could explain why there's higher case vaccination counts among those ages 30 to 39. But again, this is not necessarily what we want to be seeing. We want to be seeing an increase by age group. So just something to keep in mind as we move forward, not only looking at vaccine dissemination by race, but also by age group. The figure to your right looks at vaccine counts by dosage and then by age group. And the reason why we wanted to look at that was to determine vaccine adherence. So who's receiving the first vaccine and then making sure that they also receive the second vaccine. So even though those ages 60 to 69 have higher vaccination counts, those ages 30 to 39 have higher counts of receiving the second dosage. And that indicates to us very strong vaccine adherence. So they're taking the initiative to be fully vaccinated. Now, I'm not quite sure why those ages 60 to 69 have the highest overall vaccination counts, but lower second dose counts. And that could be something that we talk about moving forward in terms of how to make sure that older adults are also demonstrating strong vaccine adherence. So as was previously talked about, I think education moving forward here will be very critical.
Neha, if I could interrupt for a
Absolutely.
second. This, by the way, this presentation is fantastic and really informative. It just might be worth pointing out that a lot of this distribution is being driven by policy at the state level, by how the tiers are being rolled out and eligibility, and not necessarily by, it's in part being driven by access as well, but mostly at this point by who's eligible for the vaccine, and in part, as Dr. Ross pointed out. So, the first level of access was to healthcare workers, long-term care facility workers, and so on, which might explain some of the numbers below age 60. Now, in order for you to get the vaccine, you have to be over 65, or you have to have a health condition, so I can tell you in my household, my wife is not 65. There's no way she can get it ethically at 61 years old. But my son with multiple comorbidities was able to get it at age 26. So he was able to get it in that age group and would end up on your chart, even though I don't live in the city of St. Louis. So, but that's how it would play out. And so one thing I would mention in terms of your chart, it would be interesting to break this by age 65 in terms of how the policies are rolling out right now.
Sure.
And as I understand the governor's policies, maybe Dr. Eccles or one of you can correct me on this, but I understand maybe in the next 2 weeks we may open this up a bit more to tier to broader tiers, to tier 2 or whatever it is. I lose track of the numbers, to other essential workers, grocery store workers, and others. So that'll spread it across age distribution further.
We can definitely look at that moving forward. Obviously, it's really important to note that this data doesn't exist within a vacuum. Policy definitely drives the majority of these numbers, and we should use these numbers to further enhance the policies. So I appreciate that perspective. Thank you. Moving forward. Okay, here we go. So in the following, I will be talking specifically about the fatalities. During the city, during this 1 year, there's been a lot of data that's been thrown our way, and there's been a lot that we've had to process as we go through the whole pandemic. But looking specifically at our fatality counts, to me, is very important, just so that we can identify, again, the key populations that are at risk following diagnosis of COVID-19. So as you might be familiar with these figures below, that looks at the case rates in the city during the pandemic. There was the very sharp increase that's since decreased, but as you can see, there's been a slight increase above 2 deaths per 100 cases. And then when we look at the adjusted fatality average, we also see that following the initial increase, after the third wave began, there's been kind of a stagnant hold, and that has been holding for a little while during the plateau that we've been seeing in case counts overall. When we look at fatalities by men and women, it's also important to look at the odds ratio analysis. So from the overall fatality counts, we see that women have a 33% decrease in fatality odds compared to men following COVID-19 diagnosis. And the numbers that are included in this report are the odds ratios. When we compare to African Americans, Asians have a 68% decrease in fatality risk following COVID-19 diagnosis, and Caucasians have a 38.5 decrease in fatality risk following COVID-19 diagnosis. As we can see in the figures to your left, when we look at case fatality rate by sex, despite case counts being highest among females and case rate being highest among females, fatality risk among men is higher. When we look at case fatality rate by race, African Americans not only have the majority of case counts, but their fatality risk and their case fatality rate is also higher. One thing that I wanted to note was in the very beginning of the pandemic, there was a point where fatalities were exclusively among African Americans. And so that was driving the majority of the data that we wanted to get across. And this has not changed that much. There is still a great amount of racial disparity by fatality when we compare by race. So I think that that's something that we continue to keep in our minds moving forward and as we go through these new variants. And also as we talk about vaccine dissemination.
Yes.
Yes.
No, actually do this one and then I'll have a question. Go ahead, please.
Okay. This figure to your left looks at case fatality rate by race and sex. As we've talked about previously, African-American men and women have higher case counts, but case fatality rate, when we look at it by sex, is exclusively higher among African-American men. When we look at comparing African-American women to Caucasian women to Asian women, African-American women have a 67% greater fatality risk following COVID-19 diagnosis compared to all other women. African-American men have a 44% increase in fatality risk compared to other men. And also when you compare to African-American women. We also found that African-American men across all demographic groups have a consistently higher risk of fatality compared to all other races and compared to women. This has changed since the beginning of the pandemic. Fatality risk ratios calculated during the midway of the pandemic and also in the very beginning demonstrated higher fatality risk among African-American women, and these trends have since changed. But again, still highlighting African-American men and women at greater fatality risk compared to all other races. Dr. McBride, you had a question?
Yeah, unless you're going to address it on the next slide. From the earlier slide when you showed the raw counts by race, and I've seen that on one of your previous presentations. This, it's interesting, and it showed that the African-American case rates and all other rates were high in the early part of the pandemic, much higher. And we all lived through that, and we're worried about it. And it's since then the difference has narrowed. My question was, and you've done so much great work with the data. I hesitate to say, is there one more analysis you haven't done? So I'm wondering if the earlier part of that story is race by age. Was a concentration of the problem in the early part uh, African Americans of older age, particularly in long-term care facilities, or also in single homes? Do you know? Do you happen to know that? It's going to show up in your data in a minute, or do you know that from looking at the data yourself? Was that where? There you go. Thank you.
Yeah, there you go. So obviously we do have to talk about age groups. When the pandemic first began, a growing element of concern was fatality risk among older adults, specifically in nursing homes. And as we've gone through this pandemic, there has been an increase in fatality risk as age group increases. So if you look at the figure to your left on the upper part of the slide, you'll notice that, again, there's been an uptick by age group. So as age group increases, fatality counts increase. And risk ratios that were calculated also highlight these, indicating that as age group increases, as age group increases, a fatality risk also increases. And those of lower age, so ages 20 to 29, 30 to 39, have a lower fatality risk compared to those above the age of 80. And the odds ratio analysis is there on your left side for those who want to see the very specific numbers. Basically, what the odds ratios are telling us is that those ages 70 to 79 have a 50% decrease in fatality risk compared to those 80 plus. Those ages 60 to 69 have a 81%, sorry, I had to do a little bit of calculation there, 81% decrease in fatality risk compared to those above the age of 80, and so on and so forth. So of course, this indicates a greater need for continuing with our safety precautions, and also keep being mindful of examining outbreaks in long-term care facilities as we have been. And that is mentioned a little bit in the report overall, Dr. McBride, for your concerns that you brought up. So in conclusion, the populations that are most at risk continue to be the ones that have been of concern since the beginning of the pandemic. Those African-American men and women above the age of 50, with fatality risk increasing by age group. And again, those over the age of 80 continue to have the highest fatality risk. As we've talked about, there was early investment in North City for testing and medical information. And we've seen that in terms of lower case counts overall in South City. Specific areas with higher case counts include the following zip codes, as well as this following neighborhoods, but also coupled with the downtown area and Central West End. As I mentioned previously, vaccine dissemination is most common among Caucasians, making up almost 50%. And I think that greater concentration on vaccinations among African Americans is really crucial. And also encouraging or strengthening the faith in our system due to institutionalized racism that might contribute to a lack of desire to be vaccinated or lead to a lack of trust in our institutions overall. And then the specific age groups with higher vaccination counts, as I mentioned, are those ages 60 to 69 and 30 to 39. So as we move forward through our new normal, it's really important that we continue to talk about the pandemic and the disparities that they've continued to highlight. So interventions that we know are helpful and reliable, such as mask wearing and social distancing, need to be continued and need to be talked about more to ensure that we are regular and transparent to the communities that we work within. There's one of the things that a quote that I saw very early on in the pandemic is the quote that you see to your right. everything we do before a pandemic will seem alarmist. Everything we do after will seem inadequate. So it's not a matter if there's going to be another pandemic, it's just a matter of when. And it's really about taking the lessons that we have learned during this time and holding them in the forefront of our mind as we move forward with health interventions. I think that's all I have. I'm happy to take any questions or talk about any more specific data that people might have questions about. Well, thank you.
Neha, thank you very much for that presentation, given the 1-year mark that we've been in the pandemic. So very well done, very well organized and informative. So thank you for letting us know and telling the story with data in terms of what has happened with COVID vaccines, testing, and morbidity and mortality over the past year. Your work is greatly appreciated. And welcome to Dr. Moshe. Thank you very much. Do we have any questions?
Sorry, I just wanted to say one more thing. I meant to say this earlier. I want to give a special shout out of thanks to not only Dr. Eccles and the PIOs, but also the fellow EPI team. It's been a really long year. And I think that we've all had very great crash course in terms of understanding the city a little bit more and understanding the vulnerable populations a little more. But again, couldn't have done it without the rest of the EPIs. Binoche and Matt have been incredible. And so it's been great to work with them. So I just wanted to give a special thank you to them.
Thank you. Dr. Lee?
Yes, great presentation. Just like everybody was saying, Neha, very great. I do have a questions about, I know you have a lot of statistics on a lot of data, but I noticed that you did not have one that compares the vaccines to the cases. Is that because it's too early? You don't have enough? I know it's, the data is all the way to February, and maybe that's the reason why you haven't compared the effectiveness of the vaccine, where we can see a trend that the cases would have gone down if the vaccine was continued.
Yeah, I definitely think that's something that we should do driving forward. I think the main reason why we haven't done that is largely due to the fact that vaccine counts are just starting out. But we should definitely take a look at that moving forward. Thank you for pointing that out.
Neha, if I could, Dr. Blue, just a real quick question. Again, fabulous presentation. You know, I love it when data is presented and it makes me want to ask 10 more questions. So I apologize. So this is going to be a little bit in the weeds, but as your slides went by and you presented the data by race and ethnicity, which of course we have focused in on for very good reasons. I had to notice, and I had on my screen the state's website where they show the vaccination rates by race and ethnicity. And there's something notable about their data, which is the bar that's the highest is the mixed race bar, and in terms of vaccination rates. And then the second highest is Caucasian, the third highest is African Americans. It seems in your data that's not the case. And so, you know, when I first started to see, and I think the state's website's good in terms of presentation and its transparency to the extent, you know, they're presenting the data in a pretty real-time fashion. But that's one that's perplexed me from day one. And, you know, the data is what the data are. So if that's what people are putting on their cards, you know, I guess that's what it is. But can you speak to, because I didn't see that so much in the city's data, that mixed race category was the highest prevalence. Do you know anything about that, or just Dr. Eccles?
So in our vaccination data, I haven't seen the mixed race category. I don't know if I didn't see that when we were formatting this report. Perhaps Matt Haslam can speak a little more about this, but it's not something that I noted. Might be something that I take a further look at, specifically looking for.
Yeah, so this is Matt, another EPI with Neha. So the state did acknowledge that they may have overcounted mixed race individuals. So that, I don't know if it hasn't been adjusted on their dashboard yet, but the other thing is that estimates of mixed race individuals in the city by census estimate may be lower than what is actually in the population. So the rate is calculated based on that baseline population estimate. So that might be contributing to the high estimate of rate of vaccination.
Those were my two hypotheses, so I'm glad you spoke to them, Matt. Thank you.
Thank you again for, Dr. Ross, did you have a comment?
No.
Thank you again for the presentation and for all of your work throughout the past 12 months to help keep us informed about the pandemic. We are going to move through the agenda. A few items we're going to move to the April meeting. So we are going to, just to make sure we give everything the time warranted, we're going to move the American Recovery Act information to the April meeting. And also Commissioner Glass had a conflict, ended up having a conflict this morning. So under new business item C, we are going to table that for April as well. So thank you very much for the report and for your work. Extremely well done. And so we'd like to move to new business. So introduction of new Department of Health staff. Dr. Eccles.
Yes, I think the goal there was just to introduce the new staff to the Board of Health. So everyone has met Dr. Dominic Moshe, the new Epidemiology Bureau Manager, and a few other staff we have. So Ms. Julia Hughes, I think some of you have had the pleasure of meeting Julia, who's overseeing our accreditation efforts. So Julia's been with the department, I believe, 4 weeks now. So we're ecstatic to have her on board. And we also have Ms. Valerie.
Can they turn the cameras on so we can see who they are?
Please.
Hello, everyone. Good morning. I'm Julia Hughes.
This is Julia, and then we have Ms. Valerie Newburn, who is overseeing the communicable disease investigators now. And so she's been with us for a few weeks as well. So Valerie, you can introduce yourself.
I'm Valerie.
Hi.
So they've been informed that we have a very active and engaged Board of Health. And so they look forward to working with you all when the opportunity presents itself.
Thank you. Welcome everyone. And I look forward to working with Valerie and Dr. Moshe, and I'll say Julia Hughes is also she's doing accreditation. She's also been really active in doing the health equity work too. So I'll have to give her a shout out on that. She's been on a number of calls related to ensuring and infusing health equity into the Department of Health. So welcome and thank you in advance for all of the wonderful work we know you are going to do at the health department and joining in the middle of the pandemic. So we will just move to board reports briefly. Oh, I'm sorry, Julia. My apologies. You had an update on accreditation.
Yeah, that's I didn't know where I was going to pop in. So
for
the sake of time, I'll keep this brief. Good morning, everybody. Thank you for allowing me to come in and share a little bit about FAB Accreditation Board with our Public Health Accreditation Board and the history and what our plans are right now and plans for the future with the involvement of the board. So for some context, the Department of Health started our initial accreditation process in 2015, and we achieved accreditation in February of 2018 with version 1.5 of the measures and standards that were established by the FAB board. Our FAB accreditation lasts 5 years, so we are right smack dab in the middle, and that accreditation is contingent on our submission of annual reports. 2 have been submitted in the past, and we are working on our 3rd annual report, which mainly works on quality improvement and performance management. So we're right in the middle of this 3rd annual report that is due at the end of April. And we are receiving feedback and circulating this report to make sure that we are capturing as much work as we can that's been completed over the past year. So this year's annual report, like I said, focuses on 2 measures within Domain 9, which has to do with using performance management system to monitor achievement, and Standard 9.2, which is to develop and implement quality improvement processes integrated into our organizational practice. And so to pull these examples over the past year, I've been sending out surveys and having meetings with program managers and bureau chiefs to be able to compile all the activities that have, and to synthesize them into this annual report. And like I said, it'll be submitted by the end of April, and we are in the process of reviewing it and compiling content right now. Now, this is a part of a larger process as we move towards a reaccreditation. So reaccreditation will use a standard that is different than our initial version 1.5 that we were initially evaluated on. And planning what documents to use and delegating and writing narratives to demonstrate Department of Health activities within each measure is going to be a key planning task for us. And this will continue to be very collaborative in order to increase the awareness of the accreditation among staff, regardless of position, and other stakeholders, such as our board. And so there is a measure called Domain 12, which is to ensure that our public health governing entity is informed and engaged with the health department activities. And so we graciously will have the opportunity to work with all of you to satisfy 2 measures within that domain. One is that the health department governing entity is informed about the health department mission, goals, and responsibilities. That has 3 requirements, 2 of them just being brief narrative descriptions, and 1 request for examples of how the board is informed. So for example, we can submit our minutes in lieu of, in the form of like our Zoom videos. We can use that as a submission, and presentations and white papers such as the presentations that Neha has presented over the past few boards, and other presentations, we will be able to use those as well. And then for the second measure within Domain 12 is the health department's governing entity is engaged with the health department activities, which has 1 requirement with a narrative that describes our working relationship and how the board is oriented towards the department's goals and missions as well. Each of these requirements have detailed guidelines, and I'm working on an infrastructure that is going to be stored on our public our internally shared public server, so that all staff, and I will share it specifically with you, Dr. Ranabalu, and everyone else who's interested in compiling their comments to have these narratives. Again, this is not for the annual report. This is for reaccreditation that will start in 2022, 2023. And I have started to observe and collect documents for all of our domains. And I believe that is a summary. If you guys have any questions, I'd love to answer them, but for the sake of time, I will yield back my time. And I thank you for your ears for this moment.
Thank you very much, Julia. I have a couple of questions. Is there anything in particular that the board can do to assist with the accreditation efforts?
Yeah, absolutely. So when it comes to how board members are oriented towards the process of either becoming a board member, if you want to say an onboarding, I can write brief narratives and everyone can kind of circulate and put their additions of your experience, specifically both serving as our chair and as a board member. The input that you all have is going to be essential towards making sure that we're able to report accurately of what our board and how you are informed. And more specifically, I think FAB is an opportunity to show how we are able to improve and be more accountable to the public. So we're able to highlight how we can improve in the way that our business is conducted. In addition, there are opportunities in other domains that have to do with connections to organizational structures outside our community partners as well. So identifying opportunities to either establish relationships or strengthen or re-engage with community partners, as I know you are all very connected, will be a huge piece as well. So it'll be ongoing, and as opportunities are identified, we will be reaching out for feedback.
Thank you very much. Any other comments or questions about FAB accreditation? Thank you for the update, Julia.
You're welcome.
I know we have time for just a couple brief committee updates. Do we have an update from the governance committee?
Hello. Yes. Thank you, Dr. Blue. We're working on getting a retreats for the beginning or middle of April. So we're working on that, but we haven't got any specific dates. But I think it'll be before our next meeting. So therefore, we probably have to email out to all the board members once we got that retreat set up. And also, I think we're working on getting the hospitals, Board of Hospitals and Board of Health as one committee, well, as one, well, it's like in a charter change, and that's has to be done with Linda and also the city of St. Louis, where the mayor's office. So we're working on that. That's all we have.
Thank you. Communications committee?
We wrote a job description for an intern that we submitted to the head of the ambassador program at SLU to post for a social media, so for an unpaid intern to help us to augment our social media output in the public.
Linda, you're frozen.
Yeah, Lisa froze, I think.
I'm sorry, Lisa. Lisa's
Yeah.
frozen. Well, I'm going to give Lisa a moment to unfreeze, and we'll see if the academic health department has an update while Lisa is unfreezing.
So thank you. Just real briefly, there is circulating currently both at St. Louis County, well, in all three, St. Louis County, St. Louis City, and over at St. Louis University, and a survey to determine how much people know about the academic health department. There are plans currently, and Julia is part of that, along with Amanda and others, in terms of planning for our annual retreat, which I guess they'll tell us at some point whether that's virtual or in person. We had one of those 2 years ago and unfortunately didn't have one last year. And then there are efforts afoot in terms of some relationships to move us forward with regard to some of our internship pipelines and working on strengthening our future workforce as part of the academic health department. Obviously, there are other aspects with other institutions as well, but this is the part that's funded by the Missouri Foundation for Health, and that's what we have so far. Thank you.
Thank you, Craig. And I see that Lisa is back.
Sorry, I have very unstable internet during rainstorms. So we're looking for a social media assistance. And if anyone has a student who's both a social media writer, has a little experience in that and is interested in public health, please send me or Harold or Kim their resume. But we are working through the ambassador program at SLU to get someone. And then next week I'll send out some dates for our next meeting, probably on Monday. And so we'll see what our next agenda for the next month will be. But that was Dr. Mahdi's idea to beef up the social media, which we really need help on. Thank you.
Thank you for all the committee reports. And I'll echo what Dr. Lee said, that we will be having our second follow-up board retreat to talk more about committees and board activities. And the board will receive an email about that. Any questions about any of the committee reports?
I think Dr. Mahdi has her hand raised.
Okay, Dr. Mahdi is not on my Brady Bunch screen here. Dr. Mahdi?
It's a mistake. I don't know how it got up there.
Okay, not a problem. Any departmental updates?
Just one big update. So Janine Argy has been with the City of St. Louis Department of Health for the past 17 years, leading our environmental health division. She's done an amazing job. At the end of this month, Janine will retire from the City of St. Louis Department of Health, but she has been a phenomenal asset to not only the health department, but to the community at large and the St. Louis region. And so we're grateful to have her on the team. And we're grateful for her expertise, especially at the start of my tenure with the turnover that was required for me to be able to do my job. And so thank you, Janine, for everything that you've done for this department and the St. Louis region and the state.
Yay.
Thank you, Dr. Eccles. Janine, you will be missed, and I see you wrote in the chat that this is your last Board of Health meeting, and of course maybe it's your last as a panelist, but I hope it's not your last, and you can still join as a citizen because we appreciate your input. So hopefully it's not the last time that you attend a board meeting. And thank you so much for your service and for your leadership and all that you have done for the city of St. Louis and the region. And it's been an honor to have been able to work with you. And congratulations on your well-earned retirement. And we hope that you have a fabulous and restful and fruitful and wonderful retirement season. Do you have any words you would like to speak?
Well, thank you. When I had the brief opportunity to work directly with the board as the acting director, I was so thankful for all the support, and I just am delighted to see where this board has come, and the support to Dr. Eccles and all of our team. So thank you so very much. And yeah, I'll still be out there working on some food access and academic health department work over the coming months. So I'll be around. Thank you.
Thank you so much. Any old business? Okay, announcements. All right, Dr. Ross, did you have? Okay. I just have one brief announcement. The Health Equity Group did meet since the last board meeting. We met after the last board meeting, and we are moving forward. So what we decided to do was to have some students actually go through existing material. The president's executive order on race and ethnic disparities and racism that Dr. McBride offered, and some of the department materials that Dr. Eccles mentioned, including the strategic plan to look at places where we're already working on equity to try to come up with some language for the principles that we'll work through. And I have a group of 4 students that's working on that. They received the information yesterday. So we have students that are working through that, and we'll continue with the Health Equity Group after they're finished with their initial assessment of the document. So I just wanted to let everybody know that given the health equity issues that we've seen in the presentation today and the comments by the board, that we are consistently and taking some steps forward in addressing equity. So if that is all we have,
Could I dovetail on that comment
yes,
for a minute, Dr. Blue? I just wanted to use a minute, since we have a minute left, just make a comment. It relates to your equity group, and just make a comment about what's going on in the whole country and related to Atlanta and the uprising of anti-Asian violence around COVID-19 and related issues, and just sort of speak out, strongly about how awful I think that is. And I've been hearing from some of our students at Washington University, our Asian and American and Asian students are not always very loud or vocal about the anxiety or stress they feel. But they do, if you talk to them, say that this is a very stressful time and that they are feeling discrimination and negative comments related to what's going on with COVID-19. And it hasn't just started in the last few weeks. It's been going on since the beginning because of negative comments that are going on in society. So I think it's worth us, calling that out and saying that it's totally inappropriate. And it's obviously obviously led to violence around the country and an uptick in that, and that's totally uncalled for. So I just wanted to make that statement. And also, as we go forward in thinking about this, and as we look at things from an equity lens, I'd like to throw that one out there and think about our messaging and are we messaging to that population as well in the city to make sure that that the Asian population, the Asian American population is being thought of as well, because this is obviously a tender time. My son lives in Atlanta, and so that I've worried about that quite a bit. But so anyways, that's my comment. Something to put in the parking lot to think about in future meetings. Thank you.
Yeah. Thank you, Dr. McBride. That that was a great way to use the extra couple of minutes that we had. And I will reiterate, hate has no place, and it was not only unacceptable, it was an abomination. It was violent, and people were literally gunned down yesterday from Asian American brothers and sisters were murdered in cold blood yesterday, and it's an abomination, and it cannot be tolerated in this country or in this world. And we have a lot of work to do. And I almost have no words that this kind of hate continues in our country, and it's not acceptable. Thank you for bringing this up, and it's really an abomination, and has no place. And given its relation to the pandemic, and the pandemic was well, you know what? I won't even say that it was a pandemic that spurred this. It was racism, and the pandemic is an excuse. So this has really nothing to do with the pandemic. It's just an unfortunate, that was correlated in terms of time, but certainly not causal. The relationship between the pandemic and the hate and uptick in hate crimes against our Asian American and Asian brothers and sisters. And it's unacceptable, and we need to take a stand because we did last year under Dr. Ross's leadership say that racism and this type of hate is a public health issue, and we have to stand up in support of all of our brothers and sisters in this country. So thank you, Dr. McBride, for bringing that up. And in terms of health equity, racism and hate is public health. Should be a public health priority, and we have to take a stand against it. And I will say I stand in solidarity with our Asian American and Asian brothers and sisters in this country, and I pray for those families and the communities and everybody that's affected. And it's tragic. So thank you for bringing that up. I would just like to adjourn the meeting in just a moment of silence for those that lost their lives yesterday due to hate. So thank you everyone, and let's pray, send good thoughts, and think about some action in caring for and protecting our brothers and sisters and the citizens of this country. So thank you. All right, we will adjourn.